Thank you so much for having me. I'm excited to talk about the study that we've been conducting since 2019, the Kentucky Viral Hepatitis Treatment Study, otherwise known as KeyTreat. Oh, I'm trying. Here we go. All right. Oh, we went all the way back. Here we go. So we have been conducting a longitudinal cohort study in a very rural part of Appalachian, Kentucky since 2008. As you may not be aware, Appalachian, Kentucky in particular was at the epicenter of the opioid epidemic. And so we sought to study drug use trends among people who were primarily using prescription opioids. And in a town of 5,000, we managed to recruit 500 people who had recent history of prescription opioid misuse. So we had been testing them at every visit for hepatitis C and HIV antibodies, and it's an ongoing study. So when I say 70% plus had been exposed to hepatitis C, that's because we're continuing to test those who were negative at prior visits. We also did a one-time blood draw to test for viral RNA, and about 250 of those 500 would be considered treatment eligible or RNA positive. But when we asked them about when or how they had attempted to access treatment, very few had done so, and those who had were treated very poorly, which is not surprising to anyone in this room. There was a lot of stigma. And at the time when we were talking about doing this study, this demonstration project, there were a lot of Medicaid restrictions in place. So even those who wanted to access treatment were not able to do so because they had a history of drug use. So we were asked by the National Institute on Drug Abuse to establish this demonstration project and develop a model of care that could potentially be portable to other areas that were adversely impacted by the opioid epidemic. So our model of care has an advanced practice provider, so we have 2 nurse practitioners, streamline enrollment. We were able to get a research exemption from Cepheid to use the point of care RNA tests, so we were able to do same-day test and treat with SOFVEL. We also did laboratory tests as well. Hepatitis B, hepatitis C we had to do as a result of the research exemption. We had to actually confirm, and we had 100% positive predictive agreement between the 2 tests, not shocking. And we also use point-of-care RNA testing to look at adherence response and, of course, establish SVR. We're also doing extended follow-up, so 12 months beyond SVR to look at reinfection rates in this population. And anyone who is interested in receiving medications for opioid use disorder, we would provide a referral as well as payment, although 50% of the folks who enrolled in the study were already actively in an MOUD treatment program. We're also providing hepatitis A and hepatitis B vaccinations for anyone who is eligible, and provided the initial seed funding for the syringe services program in the community. So we enrolled 380 folks in a very rural county between 2019 and 2023. The theme here is we were all impacted by COVID as far as recruitment goes. But we feel that we were able to successfully recruit, treat, and cure rural residents. So our per protocol SVR rates were about 95%. We have done some initial analyses, and people who inject drugs were slightly less likely to achieve SVR, but still over 80%, and these were folks who were actively injecting methamphetamine. Very low reinfection rates thus far. Again, we're still following some folks long-term. So right now we're at 4.1% at 6 months and just 1% at 12 months. And we did have 61 individuals who chose to restart after they were lost to follow-up, reinfected. This is a clinical trial, so we did have 25% lost to follow-up in this study. But they would show up out of nowhere, and they would want to restart, and we were happy to do so. So another interesting finding was that additional providers in the area who had been very hesitant to treat people who inject drugs saw how successful KeyTreat was in engaging folks in treatment and started to treat folks as well, which was fantastic. It lowered the number of people we were able to recruit for the study, but that wasn't the goal. The goal was this was a micro-elimination project, so the more the merrier in terms of the number of folks who were treating. So I think the biggest thing for us in these very rural areas is lack of transportation. So there are no taxis, there are no ride-share services, there's no public transportation. There is a medical taxi, but it needs to be reserved. So for us, minimizing the number of visits, the same-day test and treat was absolutely essential in being able to successfully engage folks in treatment. And telehealth, while a fantastic option for a lot of folks, is not a great option here. So President Biden has a initiative to increase broadband access. He's talking about this area of the United States in particular. They don't have broadband access, and they have very little access to devices that would enable them to engage in telehealth services. So it's really on us to bring the services to these folks. So how does this fit in with the hopefully coming down the pike national HCV elimination plan in the United States? So we were able to provide a whole lot of data to the FDA application for Cepheid, and that was just recently approved. Hopefully this is a model of care that will go into a menu of different models of care that, that certain areas with differing resources will be able to choose from when they're thinking about how to engage folks in treatment. And then Dr. Vickerman and his team at Bristol are doing some amazing modeling moving forward, and hopefully some of that data will also help inform our national elimination plan, especially the cost effectiveness, which I'm pretty sure will show that this is a very cost-effective way in which to treat folks who were negatively impacted by the opioid epidemic. And I have to acknowledge Gilead, who donated all the drugs for this study and enabled us to do same-day test and treat with this population, and NIH for funding our work.